Welcome. Thank you so much for joining us at Orusa. This is our first episode of this podcast where we explore menopause and menopause narratives from the perspectives of African women. And I am excited today to welcome Dr. Brigid Monda. Dr. Monda is board certified OBGYN. She's also a lecturer at Kenyatta University. I'm going to give her a few minutes to introduce herself, and then we're going to talk about the meanings of menopause. Karibu.
Okay, thanks for having me, Marilyn. I'm Dr. Brigid Monda, as you've already mentioned, board certified OBGYN. I'm also a lecturer in the School of Medicine, Kenyatta University. I'm a mother of 2 young adults. And and I'm just glad to be here. I have a passion for women's reproductive health and now have a special interest in menopause because there's a huge gap in the management and provision of health for women in this very important part of a woman's life.
Yeah. And I think one of the reasons why I was so excited to have you is I've heard you speak, and I've heard you speak with a lot of passion and enthusiasm. And one of the things that I find particularly striking about how you speak about menopause is about possibilities. So you don't have a dooms gloom perspective on menopause. But maybe first of all, we should define what menopause is for our audience. I know a lot of people know what it is, but I think one of the most important things during our work and that I want us to accomplish with this podcast is really educating people on what menopause is and what maybe the menopause transition is, right?
Okay. So when people talk about menopause, what they're talking about is everything that goes around menopause. Menopause itself is actually a point in time. It's you're diagnosed to have, or you're said to have had your menopause when you've not had your period for 365 days continuously. From the 366th day, you're considered to be postmenopausal. So that's 12 months of no regular period for a woman who's been having her period regularly.
Okay.
So that is when you say a woman has had her menopause.
Yep.
Now, the perimenopausal period, and that is when we're having that, the period of changes in cycles, night sweats, brain fog and all that. That's known as the perimenopausal period. Peri meaning around the menopause.
Okay.
Now, menopause itself, the average age is 51, 52. It happens like about 2 years earlier for African women and Hispanic women. But it could happen anytime between the ages of 45 to 55.
Okay.
The perimenopausal period is a period that leads up to this menopause, and it could actually start as early as 5 to 10 years before a woman has her menopause.
Okay.
So women can actually start having perimenopausal symptoms as early as the age of 35.
Okay. And how do we know those symptoms? How do we know that they're perimenopausal symptoms then and not something else?
You just sense there's a difference in your body. The first thing that usually changes is your cycle. Your cycle will either become shorter or longer, a lot more painful. It may not be painful. You may get, it may become irregular. It may become heavier. It may become lighter. So there's a change in the cycle. That's usually the first thing that you notice.
Okay.
And then, of course, the things that come with the perimenopausal period due to what eventually will lead to your menopause, the night sweats. And by the way, Marilyn, there are more than 40 symptoms related to that occur in the perimenopausal period. So it's not just everybody talks about menopause and assumes it's just about the night sweats and the hot flashes.
And the hot flashes.
It isn't.
Yes.
You get brain fog.
Yeah.
You get ringing of the ears. You get changed sleep patterns. You're not able to sleep. You just get these muscle aches from nowhere.
Yeah.
You get the thinning of the tissues in the genital area.
Yes.
I've talked about changing sleep patterns. You start putting on weight, and it's usually around the midsection.
Yes.
Things just change. Yes. You don't have energy anymore. You get mood swings. Women tend to become depressive. You're irritable. You just change. Your whole character changes, and it's all because of what is involved in menopause and the perimenopausal period. Now, what leads to our menopause? Perimenopause and menopause and everything that goes with it is due to an estrogen deficiency. Okay. It's not a hormonal imbalance, as some people call it. It's an estrogen deficiency.
Okay.
So when girls are born, we're born with all the eggs that we'll ever need for pregnancy. Okay. Unlike men who actually make sperm throughout their
As
lives.
they go. Okay.
Yes.
Okay. So we are born pre-packed, as it were.
Yes.
Okay.
Yes, exactly. That's a good way of putting it. So we start using up these eggs from puberty. So by the time there's actually a natural attrition, what we call a cell death, that starts occurring for these eggs that we actually born with from the time we're actually in the uterus. So by the time we're in, we get to puberty, we have about 400 to 500,000 eggs left in our ovaries, because that's where the eggs are actually stored. So every cycle, there's a group of eggs that's recruited. And a cycle means a menstrual cycle from the beginning of one period to the next one. That is one cycle, what we usually call a month. Yeah. So in that 1 month, there's a certain number of eggs that are recruited. And out of that group of eggs that's recruited hormonally, there's this one that will respond the best to the hormonal environment. And that's the one that's ovulated.
Okay.
So if you have intercourse, you get pregnant, and then you have a baby. If you don't, then the lining of a uterus that has been prepared for that pregnancy is shed, and the cycle begins again. So you can imagine this going on from puberty to the time you get into your perimenopausal period.
Yes.
So by the time you're getting to the age of about 30, 35, you have just about 30% of those eggs left. By the time you're getting into your 40s, you have only just about 3%.
Okay.
Now that comes with a deficiency of estrogen, because that hormone is actually produced in the ovaries.
Okay.
And estrogen is the master hormone for women. It's the mover and shaker, basically does so many different things. It wears very many different hats.
Yes.
In a woman's body.
Yes.
So as these eggs are depleted, the estrogen levels are also dropping.
Yes.
And as these estrogen levels are dropping, it comes with the symptoms that we associate with perimenopause and menopause.
Okay.
And another thing, by the way, Marilyn, menopause actually starts in the brain. You know, we assume it's in the ovaries.
Yes, we do. And we assume
menopause starts in the brain. It actually starts in the brain.
How so?
You see, the brain has to send a message to the ovary to tell it to start preparing these eggs.
Okay.
So cyclically, everything works as it should. The brain uses its hormones to talk to the ovaries and tell the ovaries, recruit this number of eggs, prepare them, and then that best one is ovulated. If you get pregnant, fine. If you don't, then the lining of the uterus is shed.
Yes.
So as we head towards our menopause, remember, the number of eggs is depleting.
Right.
So the brain is now telling the ovary, you need to produce this egg.
Yes.
You need to produce this egg. You need to shed these hormones. And the ovaries are just not doing it.
Yes.
And if there's some eggs left, one will occasionally be shed. Yeah. So you get this huge fluctuation of hormones.
Period.
Yes.
Okay.
So you get this irregular periods. And then that is when you start getting now the night sweats, the hot flushes. So it all begins in the brain.
So then how does menopause then affect our brain? So I guess that's why brain fog.
Yes.
We shouldn't be surprised at brain fog.
Exactly, because every single cell in our bodies have estrogen receptors, including the brain. Okay. So when the estrogen levels drop, the synapses, the neurons, the brain cells, let me not go medical. The brain cells actually are affected as well. So I'll give an example. How do night sweats and hot flushes occur? Because of the reduced estrogen levels, the thermostat in the brain, called the hypothalamus, is no longer as stable as it should be. So we suddenly, out of the blue, just get this increase in body temperature. What does a body do? It has to respond. How does it cool body temperature? Our cooling system is sweating. So we sweat. And that is how now you get your hot flushes and your night sweats. Okay. So it's that fluctuation of hormones as well.
So does that mean we have a different brain after menopause?
No, not quite. How do I put it? Okay, let me put it this way, Marilyn. The female brain ages different from the male brain because of the estrogen receptors it has.
Yes.
But it's a physiological change. It is not a cognitive change.
Okay. Okay.
And neuroscientists
and maybe you should break that down for us. What would be the difference then if it was a cognitive change versus, you're talking about this being a physiological change. So if it was a cognitive change, what would that mean?
You're not able to function. You can't think as well as you did. You're not as intelligent as you were before.
So this doesn't affect your intelligence. No, it's not affecting your cognitive ability.
It doesn't.
But physiologically, you do have a different.
Yes.
Okay.
The interesting thing is neuroscientists actually look at it as a positive. It is thought that the neurons that are in charge of reproduction are no longer needed, so they die off. So this brain, the perimenopausal and menopause brain, is actually a leaner, more resilient brain.
Oh.
And if you look at it, actually, Marilyn, this is the time women are at their best.
And that's what we're talking about,
Yes.
right? This
Yeah.
this
Yeah,
period
exactly.
of time. And, the data is showing that we're living now about a third of our lives
Yes.
in menopause, or
In the
post-menopause,
postmenopause,
right?
yeah.
And if we count the perimenopause period, then it's a significant portion of
Yes,
our lives that we're
exactly.
living sort of in this menopause transition. And we were talking about how productive this period tends to be for women. So it's interesting that we are leading discussions, myself included,
Yeah.
Conversations on menopause with, oh my God, hot flashes and all these negative symptoms, when it sounds like the lead should be how your brain changes and what is possible in the menopause transition for you. And so how do you think then we get this shift to happen? Why are we so focused on these physical symptoms?
Because nobody's paying attention to them.
Okay.
Basically, women have been told it's a natural process. Just tough it out.
Yes.
Yeah.
Yes.
What happened, by the way, first of all, women didn't live long. Human beings didn't live long enough to actually experience menopause. In the 18th century, early 19th century, we'd be born, go through puberty, have our babies, look after them, probably be dead by the age of 34, 35, wow. 40.
Yeah.
But with industrialization and with better medical care, better nutrition, human beings are living longer. And because of that now, women are actually outliving our ovaries. We are outliving our ovaries. So that is why we're now experiencing these symptoms. Now, it's not, human beings are very innovative. We're always finding solutions for our problems.
Right.
So there are things that we have used in the past. But the attitude towards menopause, a lot of it is cultural. So I'll give an example, like in the Zulu community, a postmenopausal woman was allowed to go into the kraal because she was seen as a woman who would not bring in diseases. She was allowed to handle cattle. So they were seen as a matriarchs.
Yes.
It was a step up.
Yes.
They were treated equal to men. In other communities, the virgin was seen as the flower or the bud. The woman having children was seen as the fruit. The postmenopausal woman was seen as the seed, and she was held in high esteem. She could sit with men and make decisions.
Yes.
And that was because she no longer lost her blood. So it was assumed she retained her wisdom.
Oh.
But in other communities, that was stigmatized. It was seen as aging. And then, God forbid, you started having postmenopausal bleeding. It was seen as witchcraft. And those are some of the things that we have carried forward with us. And that is why you'll find a postmenopausal woman will start bleeding and not talk about it, because that's associated with witchcraft. And in actual fact, you may find that she actually has a cancer that could have been caught early and treated.
Okay.
So there are all these cultural nuances that come into it.
Yes.
Yeah.
And I think one of the things that for me is going to be something that we look to explore is cultural approaches and cultural, I don't want to call them solutions, but alternative remedies and approaches, I guess is a perfect word, for dealing with this transition. So for instance, I had a friend of mine who actually was campaigning in 2017, and she was going through the transition. I was not, and I was just like, I don't really understand what's going on until my hot flashes came much later. But she kept telling women, eat as if you were weaning. That was and she was saying this in Kikuyu, but eat as if you are weaning, which in the Kikuyu and Mount Kenya community is jahe, and I was like, why? And she said that helps manage the symptoms.
The symptoms, yeah.
And I think that's one of the things that I hope that we can really start to explore, because I don't know if you've seen this, and it's something that I would want you to speak about, especially as a doctor, is this rise in the consumption of supplements, especially in Africa, where our food does not have sort of the nutritional deficit that a lot of the countries in the global north do. So what do you think about supplements versus, maybe I shouldn't say versus, but, what's the necessity for supplements? Is it the same? Because for the vast majority of us, we're consuming content that is produced elsewhere, and they're pushing supplements like the panacea. And I keep wondering, and I lived abroad, I lived in the US for about 20 years, and, I know what the food was like there, and I know what the food is like. I mean, even a banana or pineapple just tastes so much different,
yeah.
so much better here. So I wonder whether we really have the same needs, sort of nutritionally, whether we have the same deficits, and if not, then do we need supplements in the same way?
I think a lot of our problems, by the way, Marilyn, is lack of knowledge. There's a deficit, and it's across the board, including amongst us doctors.
Okay.
We hardly, and by the way, that's worldwide, eh? It's like once women stop having children, we don't matter. Nobody remembers that we have needs. We have health needs as well that need to be taken care of. So, and then anytime there's a vacuum, something will always fill it.
Yes.
So that is where the issue of supplements has come in. That's one.
Okay.
And then we had the Women's Health Initiative that was, the results came out in prematurely, by the way, in 2001 and 2002. The irony of it, the initial aim of that study was to find out why women between the ages of the perimenopausal and postmenopausal period in their 50s actually seem to have a less incidence of a cardiac disease, stroke, and stroke and diabetes, but mainly cardiac disease. And then for some reason, the researchers came out with a report prematurely, before even the study was peer reviewed.
Yes.
And declared that hormone replacement therapy, or what we call MHT now, menopause hormone therapy, causes cancer, breast cancer in particular.
Yes.
And yet women had been put on menopause hormone therapy regularly since, I think, the early 60s. Yeah, the early 60s.
And this is a study in the United States.
Yes, this is
but
a
had
study that was done in the
implications
US,
globally. Yes.
So they called this press conference and released this information, and suddenly women were flushing down the loo and just stopping use of MHT.
Yes.
Then there was a gap.
Okay.
So
in this intervening period, that's when supplements, we've seen the rise of supplements. Okay.
What do we give instead?
Yes.
And as MHT was condemned, we were not given anything to replace it.
In its place. Okay.
Now, fast forward 20 years later, this study actually was critically looked at, and it was found that when it came to things like breast cancer, it was not statistically significant, an increase in the incidence of breast cancer. That's one. Two, the study was done with what we call combined equine estrogen. Estrogen that was produced from the urine of pregnant mares, and medroxyprogesterone, a progestin, not a natural progestone. Okay. Progesterone.
Okay.
That's medical.
Yes.
So, and then when it was peer reviewed, more critically, it was realized a lot of those women, the average age of the women who were included in this study were women about the average age actually was 63. And really, if you've not been on anything for the last so many years, by the time you're getting to 63, it's highly likely that you have an increased incidence of heart disease, diabetes, obesity, hypertension, and stroke.
So what's not really a causation?
Yes.
Okay.
So studies have shown 20 years later that this is actually not the case.
Yes.
That has been debunked. Menopause hormone therapy actually protects against certain cancers like colon cancer. It has massive health benefits for women because we are not replacing basically menopause hormone therapy.
I want us
Marilyn.
to talk about menopause hormone therapy, but I want us to talk about it a little later because what I'd like you to tell us is you made a really important point at the beginning talking about, once women stop bearing children, doctors are pretty much sort of done with us. And maybe we can also say, as women, we also are pretty much like, well, I'm done with my OBGYN, maybe. So what is the recommendation for women post childbearing? Is our annual, GYN visit sufficient, or what should we start to develop as a practice?
Okay. Let me say this first. The medical world, it's not just doctors alone. Basically, that is where we have fallen short in terms of looking after women. Okay, there's been a huge deficit.
Yes,
and it is only in 1983, I think, that women were allowed to be put in studies. Scientific research. One of the reasons being women are very difficult to study because of our hormonal fluctuations. We're not
difficult to study. It's just that medicine has a bias for studying the male body.
Oh, yes.
Yes.
So we're seen as, let me put it this way, Marilyn, because of the hormonal fluctuations we have, it's not as easy as it is to put women in us in to put men in a study as it would be if you put women in a study. It's more difficult.
Yes.
Because of our physiology. So instead of studies being done specifically for women, we have been seen as small men with breasts. So
Yes.
studies are done with men, and then it's extrapolated to women. So that is where part of the problem has been. It's only in recent years that now studies have started being done specifically, including women.
Yes.
Yeah, specifically for women, actually.
Right.
Yeah.
And I actually do think that this is a really important point, because I think it has implications as well for African women, because again, we're doing studies on women who live in the UK, in the US, in the Netherlands, and we are extrapolating that information, and we are assuming that it applies in the same way to African women who have very different diets, very different lifestyles. And I think that, again, we're sort of seeing the challenges with the applicability of these studies across cultures, across continents. But again, going back to your recommendation as a doctor for women who are in the perimenopausal phase, so just maybe I've got my 7-year-old now and I'm done. Maybe I'm not even quite feeling anything. Do I need to be going to my GYN? And how often should I be going? And what are some things that, if they're happening, I really do need to flag for my GYN?
Anything that makes you feel different. Okay. That's number one. Number two, see your gynae at least once a year.
Okay.
For your screening.
Okay.
I mean,
and our screening at that point should be
at least when you hit the age of 40.
Yes.
Have your first mammogram.
Yeah.
And the guidelines, although the guidelines change every year, the guidelines change quite regularly, and it depends also on which part of the world you're in. Right now, the guidelines are you do a mammogram yearly until the age of 55, and then after that, every 2 years.
Okay.
With a pap smear, that's screening. So the mammogram you're doing to screen for cancer of the breast.
Yes.
If you've not had children, we do a breast scan as well, just because of the density of the tissues.
Okay.
Of the breast tissues.
Okay.
You do your pap smear. To screen for cancer of cancer of the cervix. And remember, all these cancers, when caught in the early stages, are actually 100% curable.
Okay.
Yeah, they're curable.
So that's pretty
when
important.
They're caught early.
Yes.
And then you do a pelvic scan just to see how your uterus is, the lining of your uterus, and the state of your ovaries.
Okay.
And then there's some other tests that we will do, like we'll check your sugar levels. We'll just check your blood level, especially if you've started having irregular periods. We'll check your urine because to rule out infections. So it's a whole battery of tests. So basically once a year is good enough.
So once a year. So I think that's one thing that's really important. I think we're in the middle in Kenya. We're in the middle of this transition to Shifsha, whatever that nonsense is. And I'm not clear on how much of even our health insurance providers are attuned to the needs of women post-reproduction, so the necessity of these screenings, not as a nice to have, but actually as preventative measures. As you've said, these cancers, if they're caught early, are curable, are treatable, and which means both the expense to, to the society, but also, the cost to the quality of life of women.
That's true.
So for women who can, absolutely visit your GYN once a year, have these battery of tests. What about women who have doctors who they feel are not quite conversant with menopause?
Shop around.
I love that. Thank you. You have permission. Yes, you have permission to shop around.
Remember, this is your body.
Yes.
The decision is yours.
Yes.
If you're not satisfied with what you're getting, look, ask.
Okay.
I mean, women talk.
Yes, we do.
Discuss.
Yeah. That's how I found you, actually.
Exactly.
Yes.
So shop around.
Okay. Yeah. I think that's really important because I think it's very easy for your symptoms to be minimized. I know I'd gone to a doctor who I felt was quite good. And I remember saying, this is not. I think it's. I understand it's supposed to be uncomfortable, but I feel like I'm beyond the normal uncomfortable. I'm on this other side. And for me, they initially started with mood swings, like real rapid mood swings. I could be laughing one moment and crying like 10 minutes later. And, it threw everybody off, including me. I went and I was told, well, you're probably depressed. And I'm like, hi. That's not what I'm reporting. What I'm telling you is what this feels like. I do think that the irregular periods, I did not know that irregular periods were such a marker.
Okay.
And there was a time when everywhere I went, there were pads and tampons because that period would come whenever it wanted.
Yeah.
There was no predictability, which I think, happily led to my having discussions with my boys then about, listen, this is what I'm going through, because now suddenly they were like, why do we have them in the car? You open the glove box and there they are. And what's going on? And I was like, this is what's going on. And so we had to have a conversation with my boys about menopause, my 17-year-old at the time and my 10-year-old, about, this is what menopause is. This is the transition, and it's unpredictable, and I don't know. And when I'm, losing it sometimes, this is what's happening. But I was sort of stumbling through that. And I did not find with that doctor the support that I needed. So I think it's important that women hear the message that the body is your own. You're the expert. And anyone who's not listening is going to be a difficult partner
exactly.
in healthcare, right? And obviously shopping around is also asking around, right? For people's experiences.
One other thing I need to tell you, Marilyn, is this is a problem that's worldwide. It's not in Africa alone.
Yes.
It's everywhere. If you listen to menopause specialists like Dr. Mary Claire Haber, she'll tell you, even she as an OBGYN, it was only when she actually started going through the perimenopausal period that she realized, hold on, I am going through the very symptoms I used to dismiss in the female patients I used to see and call them the whiny women.
Yes.
Yeah, WWs. Yeah. So that is what made her start getting interested. So it's worldwide. It's not just here.
Okay.
And then in medical school, we hardly cover menopause.
Oh, wow.
Even
and you're a lecturer now.
Imagine.
So how's that changing? Is the syllabus changing in any way?
No.
Okay.
Not yet.
Okay.
We have to make that difference.
Okay.
Yeah. So some of us need to start, auditing our curriculums and insisting that this is something that actually needs to be covered.
Right.
Because the first person you'll encounter in an A&D, for example, is a medical officer. If they have no idea that this could possibly be perimenopausal symptoms, you'll be put through all these battery of tests, and the most likely thing is you'll end up with an antidepressant or being referred to a psychiatrist.
Yes.
Because the symptoms you're having are actually of depression.
Yes.
Yeah. Because you'll come in with panic attacks, palpitations. So what does somebody assume you have? Anxiety. And then you're referred to a psychiatrist,
right,
who rarely ever thinks that this could be something related to perimenopause or menopause. And then you put on antidepressants. Even us gynecologists, by the way, I'm not saying it's not restricted to just those disciplines.
Yes.
You go and see an orthopedic surgeon, for example, and you just have these aches and pains that are from nowhere.
Yeah.
Or a frozen shoulder.
Yes. Oh my God, frozen shoulder is a horrible.
Yes.
Oh gosh. Yes.
And it's assumed that maybe you may have had an injury or something.
Slept badly.
Yes,
it's going to go away. Yes.
So you're sent for physiotherapy and you put on NSAIDs, but nobody ever remembers that actually this is a result of the woman being in her perimenopausal period or being postmenopausal.
Right.
Yeah. And there are solutions to that.
And even if this is one of the signs or symptoms that, even as it's treated, it's important to then recognize what else is going on. Yeah. So I think what I'm hearing you say is that it's because of the gaps in medical knowledge and just the way medicine has developed beyond Africa, that it's also important for women to be very proactive about finding this information for themselves. That if you do find a doctor who's struggling, try somebody else. Or we do that WebMD thing and we come and you guys, I know you hate us, but we're like, listen, according to my symptoms, WebMD says.
Which is okay, by the way, because the thing is, you have to look for information, Marilyn.
Yes.
So the important thing is that I'm actually able to filter out what is correct for you.
Yes.
And filter out the wrong.
Okay.
Yeah. So there really is no problem in you seeking out information. By the way, an informed patient is a much easier patient to deal with than a non-informed one.
Oh,
Marilyn.
good.
Yes.
Good. Okay. Well,
it's much easier.
I know doctors who prefer ignorant patients, but yes, I agree. I mean, I also feel like it's then helpful to get to a place where you say with your doctor, okay, now I'm okay. You don't have to explain anything else to me. I understood this part, and I understood that you've heard me about what is affecting me. And I think maybe one of the things that's a challenge for women is trusting their doctors enough that you are not going to be dismissed. Because I think, as I've told you, my experience was horrible. But I know you've heard of various experiences. So maybe we can talk about what are some of your top lifestyle recommendations. I think I've told you I would like us to have a discussion on menopause hormone therapy, but I think I'd like that to be an episode.
Okay.
So you can take us through, this is how you should approach this decision. Not because it's a suspicious decision, but because with every health decision, it is important to be well informed and to approach it critically. Also, its availability in Kenya and for people beyond Nairobi. So we'll be doing that in a subsequent episode. But right now, I'd be interested in hearing non-hormonal recommendations to address this perimenopause and menopause transition.
I always call it the menopause toolkit because it's not just, it's not just about MHT, menopause hormone therapy.
Yes.
Okay? Mm-hmm. So the menopause toolkit includes nutrition.
Nutrition, okay.
You have to eat a high protein diet.
Okay.
At least 90 grams a day.
Okay.
And that is to replace the muscle mass that you're losing due to the estrogen deficiency you have. In fact, we need to do a topic based on just the symptoms and how they get to be what they are.
Okay.
Yeah. Stress management. Mm-hmm. You need to manage your stress because stress leads to high cortisol levels. That's a stress hormone.
Yes.
Cortisol leads to high glucose levels in the blood because you eat more. You produce more glucose, you burn less, because now you're responding to stress.
Right.
Now, what does the glucose do? It makes you produce insulin. What does insulin do?
Yes.
It's secreted by the body to push glucose into the cells. Excessive glucose, especially when it's prolonged, is then converted by insulin into fat. What happens to the fat? We deposit it around the middle. That's a whole different thing. Yes.
So our stress is how we're...
No, one of. Yeah, one of.
Okay.
Sleep hygiene. You need to sleep.
Well, we all know we need to sleep. We all know that.
Yeah.
But it's the kids, it's work, it's taking care of aging parents. It's, often at this time, women are in much more responsible roles. Yeah. And again, we have women in positions where they weren't before 20, 30 years ago. So, I mean, sleep is one of those things that we've learned to get by with fairly little of.
We need to learn how to be selfish, my dear.
Okay.
I always tell women, we need to be smart bitches.
I love that.
We need to be smart bitches, my dear, because, I mean, if you can't look after yourself, how will you be able to look after anybody else?
Yeah.
Really?
Okay.
Yeah.
And this time is one of those times when you need to call yourself to a small little meeting and say, okay.
And this is how it's going to be.
Yes.
Yeah.
Okay.
This is how I wind down to actually get into bed to sleep.
Okay.
Because if you don't rest, you won't be able to be productive.
Yes.
And that has an effect on everything.
Okay.
So we've talked about nutrition.
The protein especially.
And fiber, by the way.
Okay.
And fiber.
Protein and fiber.
Yeah, protein and fiber. We've talked about stress. We've talked about sleep. Exercise,
hygiene.
My dear.
Okay.
Exercise. And I always tell women in the perimenopausal period and postmenopausal, my dear, you have no option. There is no shortcut. You have to lift, and you have to lift heavy.
Wow. Okay.
Because we need to build that muscle and stimulate that bone. Otherwise, you end up walking with a walking stick, bent over, or with a fractured hip by the time you get into the age of 60, 65. You do not want to go down that road.
Okay.
That's a whole different topic, by the way, Marilyn.
Okay.
Yeah. And then, and then now pharmacology. Meaning now menopause hormone therapy, supplements, non-menopause hormone therapy, management of the perimenopausal and postmenopausal symptoms. So I call it the menopause toolkit.
Okay.
And then when it comes to menopause hormone therapy, we talk about the 5 W's. Who, what, why, when, and where. So who qualifies for it?
Yes.
What is MHT? Where do you get it? Why would you need to be on it, and what it is?
Okay.
We call it the 5 Ws, which we could always do in another podcast.
Yes, which we will definitely do in another podcast. I think it's helpful to hear about it as a toolkit and not as sort of the way we usually hear about it, which is sort of here's a pharmacological approach or an alternative, right? It's either or. There's very little and I'm hearing, this is an and. It's all of the above, right? As opposed to A, B, or C. Yeah. Okay, that's helpful. And in terms of lifestyle, there's lifting, that's exercise, but for many of us, we're fairly sedentary. What does that mean?
If you can walk and put on we call it a weighted chest vest.
Okay.
Yeah. Which will help you burn your calories, build your muscle. But you know something, Marilyn, it's you have to invest in yourself. You don't have a choice.
Okay.
I mean, Michelle Obama has been First Lady of the US. Look at the biceps she has. Really, she's stoned.
Yes.
Yeah. So really, it's the women here. There's so many of us who actually work out. I mean, you've seen the bodybuilding competitions we have.
Yeah.
Women are actually doing it. So you need to do it. It's an investment in yourself.
Yeah. I think that's a really helpful reframing. Also, as a friend of mine told me the other day, making ugali is also, it's really working.
Exactly.
So I think it's important, even as we talk about all the sort of modern approaches, that we also think about things that women have done and do, chores even, if you're somebody who likes to garden, you're outside, you're moving, you're bending, you're squatting,
exactly.
You're getting up and down off that ground, I know one thing I've tried to do is I try to sit on the ground a lot to force myself to do that, getting up and down, because I sit a lot and I'm reading, a lot of my work is desk work. So I force myself to sit down and then a standing desk to try and help with that. But I think chores, because women tend to be so busy, one of the challenges, I was talking to a doctor friend, and she said, it has to be exercise. And I said, when I had little kids and you told me about exercise, I never liked exercise. I don't really anyway.
Okay.
But you tell me that and it's just one more thing on my to-do list, right? Versus if somebody had talked to me about movement, if somebody had said, just find a way to move more, that would have felt a little more accessible to me, maybe wash the dishes, not because you don't have help to do that, but because you've been sitting all day and you need to try and just get yourself walking and standing up for a little bit, right? I feel like sometimes for women who are in such busy spaces in their life, when they hear exercise, they just hear, oh my God, it has to be a gym. Oh my God, I have to have an hour.
And Marilyn, I am back to you have to invest in yourself.
Okay, we must be smart bitches.
You just have to. You don't have a choice because it has long-term consequences. In fact, when we talk about obesity, for example, we shouldn't be talking about minimizing obesity. We should be talking about maximizing muscle.
Oh.
Yes. And how do you build muscle? You work it.
You exercise the muscle.
You lift.
Okay.
Yeah.
Okay.
Muscle is our calorie sink.
Oh, yes. That's a good way to think about it.
Muscle is our calorie.
So if I want to have cake,
sink.
I should lift.
Yes.
Okay.
And you can have your cake. Have your cheat days. I mean, hey.
Yes. Okay.
Yeah, have your cheat days. I mean, if you work out regularly, Monday to Friday, have a cheat day.
Okay.
It doesn't mean you can't have your wine, you can't have your cake, you can't have your occasional fries. You can. Yeah. It's just that you need to invest in that body that would then be able to burn the extra calories that you're taking in.
Yes.
Because muscle is our calorie sink. And what it does, it utilizes the energy we take in, the glucose we take in. It converts the food that we take in into energy. And that energy is in the form of glucose.
Right.
So it burns that energy and turns us into this efficient energy consuming machine. But now, remember, you're in the perimenopausal period and your postmenopausal period, which means your estrogen levels have dropped. What does that happen? What does that mean? It means your muscle mass goes down.
Okay.
When your muscle mass goes down, what happens? Your glucose levels will not be kept at the the level they should be. Now, when
optimal levels.
when the glucose levels are elevated, what happens? Insulin is secreted.
Okay.
Insulin comes, pushes whatever glucose it needs into your reduced muscle mass. There's still a bit left. You end up having fat deposition. Okay,
Yes.
that
Yes.
is one. Two, estrogen itself, because of the reduced amounts of estrogen in our bodies, we don't utilize insulin the way we should. So we develop what we call insulin resistance.
Mm-hmm.
So that again means we're producing a little more insulin that to do the same job that it used to do before.
It previously did.
Which
Okay.
means you're depositing more fat.
Okay.
Now, also because of the decreased estrogen levels, some of the proteins that carry the hormones around our body are reduced. One of those hormones that then goes up in terms of the active form is testosterone. Women do produce testosterone, which is a male hormone. Now, with this increased active form of testosterone in our blood, what happens? We deposit fat. And how do we deposit it? In the male pattern. Where does it go? Around the belly.
Wow.
Yeah.
Okay.
So there's a lot more to it than what we think.
Is critically important.
Physical activity, because of the menopause syndrome of menopause, the musculoskeletal syndrome of menopause, because of the the aches and pains that we get, we're move less.
Tell us what that is. The musculoskeletal syndrome of menopause. And what is that?
Just the general inflammation you have because of the reduced estrogen levels. Estrogen is an anti-inflammatory hormone.
Okay.
So because you have less levels, that is how you end up with a frozen shoulder.
Okay.
You even end up with gout. Can you believe it? Yeah.
Oh, wow.
Yes.
Okay. And what of people who say that these are very modern complaints? That our grandmothers didn't have this, and we're just soft life women. I mean, you hear it, that there's something sort of like there's something wrong with us,
Okay, lifestyle is one of them.
Okay.
I mean, look at a 75-year-old woman, let's say a farmer in Kitale, and compare her to a 75-year-old compatriot in Nairobi. Who comes from the house, car, office, back. I mean, their body composition and their diets, everything is different.
Yes.
We are now in a very stressful environment. And because of that, before, or even upcountry, less stress, hardly any TVs, very few mobile phones. The food is actually prepared literally from the farm to the table.
Yeah.
But here we have fast food, we have things prepared for us already in the supermarket. Yes.
Yep. Mm-hmm.
So we don't eat as well as we should, and we are living more stressful lives. So of course now the aches and pains that we get are as a consequence of that.
Okay.
Yeah.
So there may be an element of this is more pronounced.
Yeah.
Okay. But it is something, as you've said, that we can address through lifestyle changes, through nutrition, and the exercise, building that muscle, and sleep hygiene.
Yeah.
I think sleep is a really
it's important.
It's an important one because it's one that I know a lot of us cut corners with as much as we can. Yes.
And then another thing is, if you are not on anything to actually manage the symptoms of perimenopause and postmenopause, remember you're getting interrupted sleep.
Yes.
The other hormone that actually decreases in levels, there are 3 steroid hormones that we produce. Okay, sex steroid hormones, as they're called. Apart from estrogen, there's progesterone, the hormone of pregnancy.
Yes.
And then there's testosterone. Women also produce the male hormone testosterone.
Yes.
So estrogen levels drop and so do progesterone. Progesterone is good for sleep.
Oh.
We have progesterone receptors in the brain as well.
Okay.
So that is why when you're on MHT, you're actually told to take your progesterone at night because it helps with sleep.
It helps with sleep.
And then again, because of the reduced estrogen levels, melatonin, which controls your sleep cycle, is reduced. So of course it'll affect your sleep.
Okay.
Then reduced estrogen levels lead to an unstable thermostat, body thermostat. Yes. And then you start getting the night sweats and the hot flushes at night, and that interrupts your sleep as well. So you get very poor quality sleep. So you have to be very deliberate about how you go about your sleep.
And what of these people who basically say this is just, since it's a natural phase, you can just get through it? Are there risks to not addressing these signs and symptoms?
Definitely, my dear, because your risks of Alzheimer's go up, heart attacks go up, osteoporosis. I mean, you're losing your bone because you don't have estrogen anymore. Remember, this is an estrogen deficiency. condition.
Yes.
Yeah. The musculoskeletal, your muscle mass goes down, which increases your risks of developing obesity, diabetes, strokes as well.
Okay.
The genitourinary area just gets thin. The tissues become thin and friable. So intercourse becomes a problem. You're constantly in labs checking for infections in the urine, and there really is no infection. So there's nothing about it being a natural process. And the interesting thing is, Marilyn, every deficiency disease we have has a solution for it apart from menopause.
Really?
Yes.
Oh,
Diabetics are given what? Insulin when they don't have enough insulin.
Yes.
Patients with hypothyroidism, if they don't have enough thyroxine, what happens? They're given thyroxine. Growth hormone, Messi didn't have enough growth hormone. He was given growth hormone. Look at what he is.
Oh, wow.
So why aren't we replacing the estrogen that we need? Because in the long term, it has its health consequences. So it's not just about relief of symptoms.
Yes.
Because if that is what it was, then we could do the basic phytoestrogens.
Yeah.
Yeah.
Yes.
But then it's a long-term consequences.
Okay.
Yeah.
And I think that that's important because I don't think that let me speak for myself. That's not the messaging I've gotten around the menopause transition. It's not that, it's that get through it. It's sort of like grin your teeth, get through it, figure out, a Band-Aid solution here and there. But there's not been a conversation that is readily accessible, that lack of addressing these signs and symptoms has long-term consequences.
It has long-term consequences.
So in essence, you're picking what your life will be like 10, 20 years from now by not addressing some of these.
Let me ask you, my dear, why was it that these drugs for erectile dysfunction, the Cialises and all that.
And Viagra.
The Viagras, they were actually being developed for what? Cardiac disease. But then it was realized that, hey, hold on, this thing actually works very well for erectile dysfunction. What did the pharmacology world do? Pharmaceutical, produced it as the drugs for erectile dysfunction. Yet for us, we're being told to tough it out. And then, another thing is, Marilyn, women, especially in Africa, we need to stop glamorizing suffering. We wear it as a badge of honor.
Oh, wow.
We shouldn't. Why shouldn't I have a quality of life of a woman my age in Europe or in the US?
Okay.
Yeah. Why shouldn't I?
Yeah.
Yeah. So we need to stop glamorizing.
Yes.
Suffering and wearing it as a badge of honor. We need to change that narrative completely. So yes, it is a natural transition. It is true. But that does not mean it doesn't come with its problems. And we need to deal with those problems.
Okay.
Yeah.
Okay. I think that you may have hit the nail on the head there. We do sort of, that's suffering, woe is me, we can, and the people who can really tough it out are the people who are the best people, right? So sort of your value even then as a woman becomes, how much can I tolerate, which is basically saying that your quality of life is compromised in that instance.
And then for some reason, reproductive health is just not talked about. For women especially. We talk about it in whispers, in our chamas. And that isn't, we really need to bring it to the forefront and discuss it. And start making demands about what the medical world should be doing for us. Why is it that Halle Berry can go and have the presidency go to Congress and sign a grant for research for, menopause medicine? We should do the same here.
Yeah.
I tell my patients when they come to see me that, look, my dear, you're 45, you're 55, 51. You have a maternity package in your insurance. Why?
Yes.
Why can't that be converted into a menopause package? Right. And it's a lot cheaper than the maternity package. Because all you need to do is to screen yourself and then be on MHT if you need, if you do qualify for it. Yeah.
Right.
So it's us to start demanding these things. It's us to drive the conversation. And once we start talking about it, people will sit up and listen.
Okay.
Yeah.
And I think it's also for us to, and by us, I don't just mean women. I think it's also for societies to start to understand that meeting women's needs is not a nice to have. The default human being is not male.
Yes.
There are two default human beings. Yeah. There's a male and a human and a female, right? And so because there's a way that sort of responding to women's needs, whether it's health or in other areas, is seen as, well, if we can get round to it,
exactly.
right? It's seen as an imperative. So I do think that's important. I was going to ask you, is there a policy around menopause? As somebody who practices, but it sounds like from what you're saying,
there isn't.
There isn't.
Not any that I know of. But things are slowly changing, Marilyn. We're starting to talk. We're starting to discuss.
And what should be, ideally, what you've talked about insurance, for instance, what does need to change in terms of having packages that address women who live, obviously, who are living past their reproductive age. But if we were to think about a policy, what would that look like? What are some of the things that you think are important as a medical professional, as someone who's been speaking to lots of women?
Start training medical professionals who can handle menopause and everything associated with it, have it covered by insurances.
Yes.
Normalize it. Just the way we screen, we manage pregnancy. You go for your clinics, and then there is a package. We should have the same for perimenopause and women who are in their postmenopausal period of life as well. Because these are women who, by the way, Marilyn, the interesting thing is we are at our best. We've been there, we've done that. Majority of us are financially stable. We have our kids, they're much older. With all the experiences and levels of education we've achieved, we are actually at the peak of our careers. And then we can't deliver at the level we should deliver because of all these challenges that we're getting. And then it's like you're doing a presentation during a board meeting and you have this hot flush. Or you just go blank because you have brain fog.
Yeah.
Or you're so tired, you're not able to do a presentation as you should because you were not able to sleep at night. So why shouldn't we do something about that?
Yeah.
And the only things will only change, Marilyn, when we start talking about it. And it's not just us doctors, by the way.
Trying to do. Yes.
It's not just us doctors. Because if you come and see me and tomorrow somebody else does the same, then I start asking myself, hey, hold on. This is something I should be paying attention to.
Yeah. I do think that the conversation is happening. I think it does need to be a wider conversation, which is part of what we're trying to do here. And I do think it's a conversation where people always like to say, we need to have the men in the room. I actually think that what we need to have men listening, not talking.
Yes.
Really, this is one where you sit and listen and hear. In part because even for us as women, one of the things that we're doing with the talking is starting to frame and push out a lot of the things that were kind of termed hysteria.
Yeah, exactly.
Right? So we really do need to be able to have that space for ourselves to start to say, no, actually, when you go and you have mood swings, when you have painful intercourse, it's not a lack of libido. Painful intercourse is not the same.
Yes,
I get really irritated when people talk about that because I'm like, okay, painful intercourse means somebody may not want to have sex because it's painful.
Exactly.
But not that the desire has gone away.
Yeah, that's true.
And so there's a connection then that starts to be made that somehow in this phase of life, women don't want to have sex, as opposed to, is there something that is interfering?
Yeah, exactly.
Right? With your enjoyment, with your desire, right? And those are not always the same thing. So I do think that that's an important thing. And maybe we need to find ways to speak also to the women the women and men. I do remember when you were talking about the hot flashes, I do remember during the presidential election hearings, I don't know if anyone else noticed that they brought in fans.
Oh.
They did bring in fans. And when you look at the age of the women on the Supreme Court, I thought, you know what? This would have been a perfect opportunity for us to say, here are some accommodations that are being made, and with, for instance, I've done a lot of work with the judiciary, the number of women who are in the judiciary, it's going to be critically important for them to start thinking about that because they're going to have a significant number of women hitting this period at the same time.
Yeah, that's true.
I when we were talking about how women are spending about a third of their life in this phase, one of the things that societies then have to start dealing with is, what is this demographic like for you? I mean, in Africa, we keep talking about, the youth bulge, but we also
Oh,
have
yes.
a demographic,
Yes.
a significant demographic of women in this menopausal transition period. And in their most productive years.
Yes, exactly.
What's the dividend? What's the menopause dividend that societies can, nurture and cultivate? And what's the cost of not doing anything? I think maybe we need to start helping societies understand that there is a cost. There is
a cost.
There's
in
something
fact,
left.
I think in the US, they say it costs them like about $80 million a year in terms of, was it 80 or 800? $80 million a year in lost time from work.
And
yeah.
Just from the
yes.
Okay. I wouldn't be surprised if it was 800. 80 seems kind of low.
It seems low. I think it was low. 800 a year, 800 million a year.
Yeah. So there is a financial cost.
There is.
Beyond the quality of life that women have, there is a financial cost to not taking women seriously during this stage. And so hopefully that's something that we can start to unpack and help decision makers and governments understand that this is not a nice to have. This is actually, it's important for women because women deserve, as you have said,
exactly.
to abandon our suffering badge. We can hang it up.
Yeah.
But also to improve our quality of life and to improve the productivity for ourselves, our families, and our communities. That's all something we can do if there's additional support provided.
There was an interesting thing that happened. Was it 3 months ago, 6 months ago, where Standard Chartered came up with a menopause policy for their staff.
Yes.
And the HR was a man. And there was this hue and cry. Why is it a man who's talking about this and all that? And I was like, but this is what is supposed to be happening because it affects them just as much as it does us. Yes, we carry the burden of the issues. It's very, very true.
Right.
But then this is an HR who has recognized the value of the woman in that time.
Organization.
Yes. In that station of life. And the value she has to the... and he said it, by the way, we realized that our most productive staff were actually in that age group. So they have a menopause cover.
Okay.
So, and you can get anything. You do your screening and you get your HRT, whatever you need.
So change is happening.
Change is happening, but it'll only happen if we push that agenda.
Okay.
Yeah.
Okay. That's good to know. And I do know that there are, organizations, collectives, including like the Women's Health Cafe. And I'll be speaking with Kavugo, hopefully on the next episode about what the collectives of women who are demystifying the menopause transition, what these communities are doing, both for women, but also in terms of trying to change what the society is like. Because I think it's a bit difficult when each individual woman has to go and fight an individual battle.
Yes, exactly.
And that becomes a very uphill task. And not everyone is capable of doing that. But these communities are starting to have ripple effects.
Yes, exactly.
And I'm excited to see some of those. And I'm hoping that we'll be hearing, including from the doctors, about things, either there are changes in training for existing doctors and healthcare workers. I mean, the same way we have community health workers,
exactly.
And maybe not necessarily the whole slew of things, but at least in terms of cancer prevention, as we've talked about, really trying to screen early. We've normalized the HPV. And so we have a blueprint for doing these things. It's sort of using that blueprint to expand our reach. I think that's critically important. Okay, so tell me then what you think women should ask and they don't ask about this transition. What is it that we come sit there and we tell you all our symptoms and you're like, why don't you? What is it we don't ask?
Inform ourselves, number one. Demand to be heard, number two. And then look for the help that you need until you get it.
Okay.
Yeah.
Is there a list of menopause practitioners in Kenya?
No, there aren't.
Okay.
There aren't.
Okay.
And like I told you, my dear, it's a challenge. It's a challenge worldwide.
Globally, yes.
Yeah.
Yes.
It's a challenge all over the world.
Yeah.
So you may find one doctor who does, another one who doesn't. Some doctors still, they're still stuck in the 2001, 2002 era where everybody knew MHT causes cancer.
Yes.
Yeah. So it's
Okay.
really, it's a woman educating herself, getting informed, because then you're able to make informed decisions. For me, that is always the most important thing.
Yes.
And understanding that a consultation with a doctor is not climbing on a couch and getting physically examined. Your consultation, I know what I'm looking for when I'm examining you.
Yes.
Your consultation, what you need to benefit from that consultation is the conversation you're having with that doctor. You need to leave more informed.
Okay.
About what is causing your symptoms, how you're going to manage it. Don't just take a list of tests and go and do them. Understand why those tests are being done and what we're looking for.
Yeah.
And then discuss the results with your doctor. Understand the treatment you're being put on. And it's not just about menopause, my dear. It's about everything.
Okay. So really, we need to be more engaged.
Yes.
We really should not be passive consumers.
We're no longer at that point in time where the doctors are next to God.
I'm glad you raised it. Because I do think a lot of people have a reluctance about approaching their doctors, and especially if you have a huge age difference with your doctor. And I think what I'm hearing you say, which is really important, is approach this as a conversation. Seek to understand, ask questions, understand what the doctor is looking at and looking for, and explain and expect to be heard when you have symptoms or signs that are causing you, are interrupting your life,
and please understand it's your right. Please understand it's your right. It's not a privilege.
It's not a privilege. The more what you've said about suffering and understanding that it's your right, I think really what we're saying is there is an unlearning that women have to do about how we've been taught to engage with medical professionals and systems, generally, which is basically, tunaomba, tafadhali,
that has to change.
We need to change that a little bit, and that's our work. That's not anyone else's work. Okay, well, that's very helpful. So I'm looking forward to having you come to discuss our next episode, which is going to be on menopause therapy.
Oh, I'd love to do it. Yeah.
And as I said, I wanted this to be a separate episode because I do want you to do a very little bit on the debunking of the study, but you've told us about those W's. Were they 5?
Yeah, the 5 W's.
The 5 W's. Yeah. So going through the 5 W's and helping women understand where they are and when they might want to seek this alternative, not alternative, this treatment that is part of the menopause toolkit, as you have taught me.
Yes.
So within that menopause toolkit are lots of things that anyone can have access to: the nutrition, sleep hygiene, the exercise and building muscle, and then of course the pharmacological approaches, as we've talked about. Yes, mental health. I like to say mental wellness, but that's an area that is not quite lumped up here, but it seems, and maybe it's not related per se to the menopause transition, but to the things that happen to women during this time. But what are some of the things that you're seeing, and what are some of the things that women need to be careful about?
One, we need to debunk this thing that if somebody has issues and they need to see a therapist, it means they're mentally ill.
Okay.
They're mad.
Yes.
Your next stop is Madare.
Yeah.
Okay. We need to normalize seeking help from therapists because they have a very important role to play.
Yep.
Okay. Seeing a psychiatrist does not mean you've got, you're sick.
Yes.
You're mentally ill.
Yeah.
Per se. So we need to demystify, debunk, and again, get people to think about it differently. Because you'll tell a patient, my dear, you really need to see a therapist. And she's like, how do I go and tell a stranger all my secrets? It isn't that.
Yep.
This is a person who is not emotionally connected to you.
Right.
So is neutral.
Yes.
And is trained to be able to help you heal.
Navigate.
Navigate the, that journey to healing.
Okay.
And to actually being, sorting out whatever issues you're dealing with. So we need to change that narrative as well.
Okay.
A lot of peri and postmenopausal women do have issues also related to the transition that they're going through. Some symptoms become worse because of all the changes that we're going through as well. So we do need to seek help. Again, menopause, perimenopause and menopause also comes with changes in for example, dopamine and serotonin, the feel-good hormones, things like oxytocin, the bonding hormone.
Yes.
So that actually does come into play as well. Yeah.
Yeah.
Remember,
so it is a time that it's a transition that might actually make you a little more irritable and more vulnerable
to getting depressed, to getting depressed.
Okay. Well,
getting anxiety.
That's important to know. Yeah. So thank you. I think I'm hoping we've covered many of the high-level topics today.
Yeah.
I think for me, what's really important for us at Orusa is to have African-centered discussions around the menopause transition. And I keep calling it the menopause transition so we can leave this menopause as an event.
Yes.
And to include the perimenopause and postmenopause phase. And to really talk about the power and possibilities of women and for women during this transition. Thank you, audience, for joining us. We're looking forward to you joining us on subsequent episodes. As I said, we're going to have Dr. Monda come back to talk to us about menopause hormone therapy. But thank you very much. My name is Marilyn Kamuru, and thank you for being here at Orusa. Would you like to?
Yeah. And thanks for having me, Marilyn. Yeah.
Anytime.
And I'll be glad to come back.
Asante sana.
Yeah.